Now, instead of bringing American data, I thought, for a change, I'll bring you Sicilian data, okay? Because I thought, we're going to go out there and do better than Sicily. I've never in my life challenged us against Sicily, so I just wanted to do this. So this is Sicilian data where they started vaccinating in 2001, 2002, and they didn't do very well. It took them a while to get good coverage. New Zealand's sometimes like that, aren't we? But we're not going to be this bad this time. And as a result, you can see that both for notifications and hospitalisations, how it dropped, comparable to as the coverage went up. Interesting, eh? So really nice correlation. So I'm hoping that if we started really high, like if we get similar rates to MMR, you'll be seeing hospitalisations drop off dramatically really fast, okay? So coverage makes a difference to outcome. Really nice example. Now, so this is back to the point about the impact. When it's still in circulation, so when you've got wild varicella in circulation, you can see higher incidence of chickenpox in older adolescents. Therefore, most countries vaccinate non-immune adolescents. Now, this is a no-brainer. If anybody hits adolescence and has not had chickenpox, now they should be vaccinated. This is an absolute no-brainer. Private market, public, whatever. Anyone who's an adolescent with no history of chickenpox, you'd be crazy. Adults, any in this room who haven't had chickenpox, vaccinate, you know. So many countries fund adolescent catch-up programs. And what are we doing? Do you know what we're doing? Funding, okay, we're funding 11-year-olds, okay, in general practice. Now this is not an active program. This is just if you see 11-year-olds in general practice who have not had chickenpox or not had the vaccine, they get a free vaccine from July next year.
Nikki, do you know if it will only be the 11-year-olds?
Well, sorry?
Will it only be the 11-year-olds?
It's people who are 11 from the 1st of July next year going forward. In the same way, it's kids who are 15 months from the 1st of July next year going forward. So there's a sort of a cut-off point in time. And so that means kids who are 1st of May 2005 and then count back 11, you know, that group and that group. Yep.
They'll be all picked up when they hit 11.
Well, that's the question. How would we pick them up? We can't easily. So if somebody's got any creative ideas about how we do that, at the moment it's just completely opportunistic.
I mean, I suppose you can just send out a letter and go, if your child hasn't had chickenpox and they're 11-year-old, just send out that letter. I mean, it's an easy enough.
Actually, that's probably the easiest way to do it, is once a year send it out to everybody turning 11.
We'll do that for,
that's such a good idea.
17, 18-year-olds for meningococcal go to university.
That's such a good idea.
Same thing.
Actually, you're right, and nobody's going to take offence, are they? It's not like, has your kid had sex? You know? They take offence with that one. I don't know why.
Yeah, I mean, we have a big response to the meningococcal.
Yeah, okay. I like that. I'm going to take that one back too. That's a very nice idea. That's really nice. Okay. Herd immunity works. I just wanted to make that point. And so, once again, not just American data, Canadian data, that decreases in varicella circulation contribute significantly to declines in hospitalisation for infants and in adults. So the advantage is that you get herd immunity everywhere. So that's why you get an overall reduction for adults, even if you've got vulnerable adults. Okay. Does it have side effects? It is alive attenuated, so you don't want to give it to immunocompromised. I think most people are familiar, you can get an attenuated rash, you know, like you can with measles. You can get a varicella one too, 5 to 12 days post-vaccination. That is theoretically transmissible. So if somebody comes out with spots, cover them. And then, you know, as long as you don't touch them, they're not likely to spread. Okay, so there's some rash. Now, there's always this question, could you transmit the virus to others? And this is the question, if you've got a severely immunocompromised person in contact with your vaccinated kid. So I would normally say, look, unless you've got a severely immunocompromised, just cover the rash. It's enough, you know. You're not going to transmit attenuated through respiratory route, okay? But if you had somebody that was really severely immunocompromised and you're really worried, I'd isolate just to be safe. And you can use antivirals if you're really worried. So that's just the one caution. There's a couple of case reports in the world literature that it can spread. Unlike measles, this one can spread. All right? We all happy with that? Now, as usual, the list of noted but not causally linked. Now, obviously, if you had attenuated varicella in an immunocompromised, you could get encephalitis. And the same with all these things, because you see them in varicella anyway. Anaphylaxis is incredibly rare for some reason. I don't know why it's more common in some than others, but it's really rare with varicella vaccine. Okay, here's your safety stuff, okay? There's always a slight possibility of ITP. It's much more common with measles, but it's possible with varicella. Anaphylaxis. Now, here we go, febrile seizures. I'm going to talk to you about febrile seizures, and I'm going to talk about them later. Okay, I'll come back to those. So, pretty safe, usual live attenuated, immunocompromised, particularly cell-mediated apparently. Okay, so people with cell-mediated immunodeficiencies, don't give them the vaccine. There are kids that you actually want to use it in, but you just want to monitor closely. So if you're not sure how immunocompromised they are, firstly think, secondly think, thirdly think, and fourthly ask advice, okay? Because a lot of these people actually need the vaccine. They're really high risk. So some of them we can vaccinate, okay? Now, there is a vaccine, 4-in-1 MMRV. Why are we not giving that at 15 months? Okay, there's one reason. At 15 months, there's your peak. So firstly, the MMR vaccine causes fever. When you put the varicella in with the MMR, you get an increased incidence of fever. Now, between 15 and 18 months is the peak age for febrile convulsions. So you see more febrile convulsions, all right? So we could give MMRV and we would see more febrile convulsions. So most of the world are choosing not to use MMRV for the first dose because of the increased incidence of febrile convulsions. Now, you can go out there and ask loads of people, and some people will say, I'm happy to live with the risk, and most people would say, I'm not. You know, it depends how you ask people, how you do your literature. Most of the world is coming down on the side of either shifting the age, so you don't give it at 15 months, or starting with varicella separately.
Funded in Australia?
Single dose is funded at 18 months. They're talking about going to a 2-dose. And the possibility they're thinking about is you could actually maybe give MMRV at 1 year of age. Now, there is still an increased incidence of febrile convulsions, but it's less because of the age group. So that's the conversation they're having. Currently, they give varicella separately. Okay. So use of MMRV doubles your risk of seizures. Okay. But if you use it if you use it as dose 2, you see, because you've already seroconverted so whole many the first time, you're not going to see so many febrile reactions. You don't see an increase in febrile convulsions. So if and when we introduce MMRV, whatever time we give it, we'd be doing that as a second dose. Now, at the moment, it's the age of 4. But if we mess around with the schedule, we might be able to bring both of them into the toddler years, get rid of 4 injections. Now, this is a different issue. This has nothing to do with varicella, but this is really interesting. If you delay your MMR dose until 16 months or older, you increase your relative risk of febrile convulsions 3 times. This is really, I just chucked this in as an interesting point for a reason for people not to delay. Because it's the age when you see more febrile seizures. You see, the peak of febrile seizures, I think, is 18 months. So the later you give your MMR, the more you'll see febrile seizures. Okay? So it's better giving it earlier. Interesting, eh?
That's worth putting in the recall letter, isn't it?
Yeah. Yeah. Yeah, give it earlier. Yeah.
I mean, it often is given late because around the 15-month mark, they were at day care and things,
Yeah.
getting sick, and so then the parents go, oh, I'm not going to do it, and I'm going, well, no, that's not a contraindication, but they delay it anyway. So they are often slightly over.
That's why I stuck that in there, because we often do delay 15 months, yeah. And in many other reasons, it's not a big problem delaying 15 months. So this is one of the few reasons it is a problem. Interesting, eh? Of course, if you give it too early, you get maternal antibody interference, which is why we're having a discussion about whether we could give it at 12 months or not. And there's a little bit of maternal antibody interference, a bit, but not a lot. Nothing's black and white.
But every so often they do overseas catch-ups. You find that MMR has been given 3 days before they turn 12 months. You know.
We've got this 4-day rule. For no very good reason, we had to draw a line in the sand. So if it's 5 days before, we don't count it. If it's 4 days before, we do. We've got to put a line in the sand somewhere. If you wonder why we come up with these rules, it's because we need something.
I was all in favour of bringing that, you know, really good to have that at 12 months.
Yeah, but then if we give it early, we're in trouble.
Early,
Exactly. So it's a bit of a toss-up all over the place, eh? Because I'd quite like to do 12 and 15 months. I think it'd be really nice, but, you know, and also I think 12 months is a good headspace thing. But yeah, you don't want to give it early. Yeah. My son would love that one too, wouldn't he? Yeah. Post-exposure prophylaxis really works, interestingly, because it doesn't work with all vaccines. If you give a single dose 3 to 5 days after exposure,
We do lots of that.
Yeah.
Especially at the moment because there's so much chickenpox going around. Everyone's phoning and asking.
I didn't realise it was quite so effective. So it's definitely worth offering, eh? Yeah, because it's a bit mixed with some of the other vaccines. And even if you get breakthrough, you've still probably attenuated it. Contraindications are the usual ones, okay? Obviously, you've got the whole immunocompromised stuff, okay? Relative contraindications is always as kids on salicylates. I don't think I've seen one forever, but, you know, I dare say they exist. Now, here's where, you know, think about it, you might be able to give it, okay, is mild immunocompromised. I just leave that there for her. Breastfeeding is fine, okay, no problem. Big take. Pregnancy register data. Okay, so if it accidentally is given in pregnancy, this is going to happen, okay? Like we've seen with MMR, we will accidentally give some in pregnancy. It looks like it's actually not a problem, all right? So once again, you don't want to give live attenuated in pregnancy. You should ask, but if you gave it, I think you can reassure people that it looks like it's not a problem. So I've put that register data in there just so that if anyone hits this problem, do not feel like you have to give up medicine, okay? Because it's probably not as big a problem as people think it is. And it's going to happen to one of us. I know it is. Right, immunocompromised. This is the whole point of you don't want to give it, but there's some that you might be able to, and if you get it wrong, you use antivirals, because chickenpox is so devastating in immunocompromised kids. I'm hoping that when we get good herd immunity, it's going to be less of an issue. But until we've got herd immunity, we've got a heap of kids out there who are really high risk. So I think hard about mild immunocompromised and whether we can vaccinate. And now where are we up to? Oh, Zoster. Okay. So if you vaccinate, does it affect Zoster? It does reduce your incidence of Zoster. Yes, because you've got basically a munched up vaccine on board. If you remember that picture of the bug with his broken legs, we've got an attenuated bug on board, so it's less likely to come out later as Zoster. But it's still in us, so we can still get Zoster post-vaccination, but the rates are much lower. So that's a winning reason for having it, okay? Now there was a different argument. The reason the Europeans delayed introducing chickenpox vaccine for many years is they were worried about what we call exogenous boosting. So if you're an elderly person, what brings your Zoster on? The theory would go that if you cuddle your grandchildren and get a lot of chickenpox, it boosts your cellular immunity and then you're less likely to get Zoster. Okay, so people thought that having lots of chickenpox in the community would reduce the incidence of Zoster. Now that's probably not true. Okay, it's probably not true, or if it is, it's only a very small factor. This is a really cute study in astronauts that they're sitting up in space and they saw cellular immunity boost to Zoster and they clearly weren't exposed. So it's more like endogenous factors that boost our cellular immunity. Does that make sense? So the answer is it was an interesting theory and it hasn't been proven, okay? And particularly once again in the States where they've been using it for so long, they are not seeing an increased incidence of Zoster in the elderly. Obviously, once the vaccinated cohort get through to elderly, we're going to see a lot less Zoster. But in the meantime, we'll probably still be using Zoster vaccines. Does that make sense? So that was an argument why many countries didn't introduce the vaccine for a very long time. That's it. Delivery. Okay. From July 2017, a single dose at 15 months. And if I say this really fast, we'll all feel fine. 4 injections. Okay, 4 injections alongside Hib, PCV10 and MMR. Then this catch up in general practice at 11 years. I like the idea of just routinely sending 11-year-old notes out. I think that's a really good idea. What I would say is parents are a bit anxious about this. They clearly are. But we, as the vaccinators, are much more anxious. And if we get comfortable in our skin, and I did put the boys in too, so I nearly just put the girls in. It was so sexist of me. Okay, so the girls are a little bigger than the boys just because there's more girl vaccinators there. But if we're comfortable in our skin vaccinating, we impart that to the parents.
Are parents still going to be able to opt to do private vaccination before the 15 months?
Very good question, yes.
Because a lot of people are
Very good
already doing
question.
private vaccination in 9 months.
Yeah. And until we get herd immunity, they're going to get chickenpox. Yeah. So yes, they can from 9 months.
But it will still be private funded before
15 months. That's correct. But yeah, if you think it through right now, while there's lots of chickenpox.
Why wouldn't you? It's another 6.
And if you've got a 3-year-old who wants to get the vaccine, you have to pay for that?
Correct. So it's anybody who's born on, what did I just say, 1st of May 2015, who's 15 months on the 1st of July. Same principle for the 11-year-olds, eh? So, 4 vaccines at once is not great. It's not ideal, but we know we can do it. We've done it before for various other things, so it's not ideal. I think in the long term, we want to look at our schedule and shift it around. And there's schedule options, like particularly going to a primary course of 2 plus 1, well, instead of 3 plus 1. And I think long term, quite a few of the European countries have done this, and we'll be looking at whether we can shift. And then if we did that, then we'd have 2 visits under a year of age and maybe 2 visits in the second year of life. Okay? Something like that. I'm just guessing and speculating. In the meantime, it's about our confidence and technique, okay? And having vaccinated somebody who wriggled on me the other day, I thought, thank God practice nurses do it mostly. I was like, damn, wriggle on varicella.
Inability to clean for 2
visits, yeah.
Clean for 2 visits?
If you think about it, okay, so for those, I think I've got it in my questions, okay, about if people choose the second one. So just quickly, adolescents and adults says recommended but not funded. For goodness sake, anyone who hasn't had a history of chickenpox, probably about 70% of them have still had chickenpox. So you can do serology, but I think you often have to pay for it. So just be aware of that trick, okay? Serology is still negative vaccinate. Those born in tropical countries in particular may have missed chickenpox, okay? So think about tropical countries. So I just think we start thinking about the whole community and who's missed out. Okay? Other national schedules, variable 1 or 2 doses. Second dose is usually with MMR. Role of catch-up campaigns probably doesn't work. So most countries are doing what we do, which is just offer those who've missed out the vaccine. I just mentioned surveillance there. Questions? You asked that question. Very good. Okay, actually I've got that wrong. It's from 9 months. Can somebody correct that? Sorry, it's from 9 months.
One's 9 months and one's 12.
Well, you know, it doesn't matter. Even though it says, oh, though you'd be outside licensure, sorry. You just need approval. I don't wish to give 4 injections at once. Just check. You know, this is this is our confidence. And one of the reasons I say, are they sure, is that we remember men's B days and we remember toddlers who hated practice nurses, didn't they? They come back and back and back for more injections, and they have got great memories. So my are they sure is that means you have to come back and get another injection another day, and personally I think that's harder. But that's what I mean, toddler memories, fantastic memories. If they are sure, we're going to advise giving the 2 live first. 2 live you can give together, but if you give 1, then you have to wait a month before you give the other. MMR is the most important. We always give MMR. So if people want to split their vaccines, always give MMR first, okay? And so I would advise MMR varicella first, and then the subunit anytime afterwards. That would be my advice, okay? Reluctantly, you know, I think it's really hard bringing toddlers back. So not ideal, but we can do it, okay? What were my other questions? Okay, I think we've answered that one, eh? A lot of people are going to be asking this one. We're aiming, easiest to say is, we're buying what we can afford, and once we get lots of people vaccinated, we'll stop the spread of varicella, okay? Can't purchase it at the moment, okay? So, I mean, if people wanted to, they could, but you can't, it's actually not on the private market. Okay, I think that was it. Ring protection, okay? If you've got a history of varicella, there's one differential diagnosis. What's a differential diagnosis of chickenpox?
Is it eczema herpeticum? No?
Because that's actually got herpes in it. No, it's smallpox. So I think that if they think they've had chickenpox, they have. Yeah, so no clear history, they may still be immune. So then you've got a choice. You could either just vaccinate or you could do serology. And in a sense, it just comes down to cost. Okay? It does absolutely comes into cost. Right, I mean, we just whip through rotavirus. I think you guys are familiar with rotavirus. So the vaccines are live attenuated, and these are the antigens they're trying to target around the outside of it, okay? So it's quite a complex little beast. Really, really common, very common, and really we're trying to prevent hospitalizations mostly, okay? So we're trying to prevent severe rotavirus. Everyone remembers the history of rotavirus vaccine, that the first vaccine off the market was shown to have definite association with intussusception. It was withdrawn, okay? So the first one definitely did have an association. The vaccines we're using now, there is a clustering effect that you do see in rare cases, a clustering effect of intussusception, particularly in 7 to 14 days after vaccine. Now, whether it's actually causing an increased instance of intussusception overall, or whether it's just the clustering at the time bringing the disease earlier, we're not sure. So Australia thinks it's seen an increased instance overall. So there is a possible association with intussusception with all the live attenuated rotavirus vaccines. Okay, so overall we're on the lookout for intussusception, which is why this is the only vaccine where you've got to give it within a time frame. That's why. Now listen, you could give it outside the time frame. You'd be outside of licensure and recommended advice, so you'd have to make bloody sure you told the parents what you were doing, okay? So if somebody turns up 2 days late, get this quite a bit, you're not meant to give it. It's meant to be absolute no. If we give it knowing what we're doing, okay? So it is, you know, you can't do it under authorization, that's for sure. All right? So we are moving from Rotatec to Rotarix. So Rotatec, they're both live attenuated. This is a pentavalent human bovine. If you say bovine, it sounds so much nicer than cow, doesn't it? If you say porcine, it's so much nicer than pig. So it's a human cow assortment. Yeah? And it's got these G types and 1P. Whereas this is a single human rotavirus strain. Now, interestingly, this one's got sort of broader serotype distribution, but they both act very, very similarly. We cannot see that one is better than the other. Nice being 2 dose, okay? Do they work? Yeah, they work fantastically well against nasty disease. The sad thing is that they work particularly well in Western countries and less well in developing countries, and I think because the strains they were developed for came from Western countries. So this is the inverse care law, which pisses you off, but hey, it's good for New Zealand. So do they work? Yeah, and they work particularly well in high income settings. New Zealand, I didn't bring any New Zealand data, we have had dramatic reductions in rotavirus, absolutely dramatic. It's stunning. In fact, it's an unsung story that I think we should at some stage have a party for, because it's, you know, no diarrhea and vomiting, you know, because it's an unbelievable story. You know, we just slipped this vaccine in, everyone got on and did it, it's dropped so the anti-immunisation lobby don't mind, you know. And nobody's had dramatic intussusception that's hit TV1 News, you know, so we've done all right with it. So it's fantastic, you know. So this is just data just to show you that it works, but obviously they're not matched against each other, okay? So these are different trials in different settings, so don't compare them. They both work pretty well as each other, all right? We know that you can get some mild diarrhea after it, you can get some smelly poos, and you get very windy, and we're always on the lookout for intussusception. My question in primary care is whether we're seeing mild variant intussusception, because now we're looking. So the clinical discussion used to be intussusception ended up in hospital, really obvious, whereas the more we're looking now, the more we're seeing these, I reckon, possible early intussusceptions that sort themselves out. And of course nobody ever looked before because we didn't know about it. So it's sort of interesting, eh? The more we look, the more I think we're seeing mild variant intussusceptions that often settle by themselves. Contraindications, I don't think there's anything new there. Right, this is the one where we got it wrong. A history of intussusception or uncorrected congenital malformation of the gastrointestinal is not a hernia repair. No. It is absolutely not. But I suspect that's somebody reading that wrong. Yeah. And SCIDs, okay. First dose at 6 weeks, second dose at 3 months. This one's different, got to be complete by 24 weeks of age, okay. So this is getting in tighter. You got less time than the other one. Always administer this first before the injections because it's got sucrose in it, and sucrose will reduce your pain, okay? So always give your drops first. It mediates, it reduces pain and distress. So what we advise now is you give this first and then you breastfeed, and you vaccinate while they're breastfeeding. We're trying to do a video at the moment just to help people to show, because it's just positioning issues about how you breastfeed and vaccinate. And once we get used to that, it seems a really cool thing to do. And when parents get their head around the fact that the kids aren't going to go off breastfeeding if you inject them while they're breastfeeding. We're also doing a video at the moment around 4 injections at once at 15 months, just so that to support people in holding and how you do it. And hopefully the video will do it well, we hope. Okay, administer first. Hand washing, because it's live attenuated, so you can spread it. Now, one could actually say don't hand wash and spread it. A bit like polio, eh? So, you know, if you do, the only time this is really important is in neonate units, okay? So give it in neonate units, but make sure you do good hand washing. We think we can interchange. Most of the world says if you start with one, you can complete with the other. Okay, so when we switch over, it'll just be a switch. Preterm infants, oh, was that? Any questions? You're all good? Preterm infants vaccinate when they're due. There is some concern in a couple of neonate units, they're worried about transmission. Well, quite frankly, I'd be more worried about rotavirus, so I think they should vaccinate. And standard hygiene stops the spread. Wash your hands. That's it. Pneumococcal brand change.
So if you're changing your brand from Rotavirus to Rotavirus,
Yep.
do you then just go straight to the 2?
Yeah, so which way round do you go? So if you've done 1 Rotatec, you need to give 2 Rotarix. But if you've done 2 Rotatec, you give 1 Rotarix.
Yeah, so
if you've done 1 Rotarix, you need to go 2 Rotatec.
Yeah.
Just because you've got 3 to 1. Or so go on the more conservative side. Does that make sense? So because, yeah, so if you've had 2...
As long as I have 3, it's not matters.
Thank you. Oh, thank God I've got you guys here. It was getting hard. Okay, big argument about pneumococcal conjugates, okay? We had a big stoush about it. Okay, so pneumococcal vaccines, we introduced pneumococcal conjugate and 23 in 2006 for high risk. Then the conjugate went on the schedule in 2008. We replaced the conjugate, which had 7 serotypes, with a 10 serotype in 11, and then we replaced the 10 serotype with a 13 serotype in 14, and we're going back to a 10 serotype, okay? Now that looks like a backwards dose, but it's not particularly, okay? Do they work? Yep, they work. Isn't that cool? I like those with little arrows showing where it goes down. Nice, eh? Vaccine works. This is data from GSK actually, and I quite like this. Has he also? Yeah. It's got number needed to vaccinate on. I quite like this. So we know with pneumococcal disease that right at the top, the small numbers, but the nasty is invasive pneumococcal disease. Lab confirmed, long lab confirmed, and then the bigger hunk of pneumonia, and then a bigger hunk of the role pneumococcal may or may not play in otitis media. So you've got all these different numbers, and you can see that the number needed to vaccinate to reduce the tip of it there, which is lab confirmed ITB, is about 667. But if you get down to any outcome, it's probably about 1 in 4. So it's pretty good odds. Does that make sense? So we know pneumococcal disease has got this burden. Now the other thing he showed us is that's the overall burden of IPD in a whole lot of countries. So New Zealand is purple. There we are. So this is the overall measure of IPD. Now it's not that Denmark's got more than anyone else. It's probably they were looking harder than anyone else. Okay. So that's the overall burden, and that's what happened after conjugates were introduced. Okay, so it's about 70% reduction overall. So it's not as effective as measles vaccines or HPV vaccine, but you know, it's still pretty good. Okay, 70% reduction overall in IPD. Okay, vaccine type IPD works for, okay? So more than 90% reduction when you look at vaccine type IPDs, okay? Now, what happens is you get replacement, of course. So 19A is the type that is in 13 but not in 10, okay? So, but overall 19A is a very small, okay, it's very small numbers. Okay, now this one here is non-vaccine type, so we're seeing a bit of serotype replacement. So I think this is a very nice overall picture of what happened. So you've got some increase in non-serotypes. So we've gained a lot and we've lost a little bit. All right? So does it work in New Zealand? Well, the cool thing in New Zealand is actually we've done better against for Māori and Pacific than we've done for others. So the reduction overall in invasive pneumococcal disease has been more dramatic for Māori and Pacific than others, which is really nice. Hospitalisation for all-cause pneumonia, so we introduced it in 2008. So this is all-cause pneumonia, which is big numbers. So that's really cool. So it's nice, it's looking nice. So these are the vaccines. This is the one we have been using. This is the one we have been using. PCV10 does not have 2, 3 and 19A in it. Now, quite frankly, 3 doesn't work anyway, so ignore it, okay? So even though this has got 3 in it, it doesn't really work. So this one has got probably 2 less serotypes. And the one that really matters in New Zealand is 19A. And the bottom line story is that Synflorix has some cross protection about 19A, but not complete. So it works pretty well, almost as well as PCV13. It may be just as good, or it may be slightly worse. On the upside, it's got a conjugate that's probably more effective against otitis media. So it may have better effect against otitis media. These are both maybes, all right? So overall, there's not a lot of difference between them. Type 19A, we can't tell the pattern. It comes and goes all over the place. Okay. Right, so we're changing from 13 to 10, all right? I think they're going to act pretty similar, but we will watch those 2 serotypes that are not in 10 and check. And if the rates keep increasing largely, then that would be an argument to go back to 13. In the meantime, because we're not totally sure, we continue to use PCV13 for the high-risk kids. Now that gives everybody in this room a headache, all right?
23
Plus 23 afterwards, yeah. So all high-risk kids, we still need to stock Prevnar 13 in the fridge because we give the high-risk kids Prevnar 13 followed by Pneumovax 2 months later. Okay, that's a bit of a headache, eh? That's what we used to do, eh? So Synflorix for everybody, high risk, Prevnar 13 followed by the polysaccharide. Now just to remind you guys that polysaccharides are pretty crap vaccines. Does Pneumovax 23 work? Well, it does a bit against invasive disease, but against nothing else. All right, so it's not a great vaccine. Why are we using it? Because it's got 23 serotypes in it. All right, so we use the better vaccines first, the conjugates, and then we boost with the polysaccharide because you get broader serotypes, okay? So crap vaccine but broader serotypes. Great vaccine but narrower serotypes. So particularly for older people, the serotype distribution is broader. So you want to use both, okay? So there we go, high-risk groups, PCV13 followed by the polysaccharide. There's a pile funded, they're considering some more. The vaccines are interchangeable in practice. Okay, if you start with one brand, you can switch to the other. High-risk groups, remember to use Prevnar 13 plus Pneumovax. Everybody else use Synflorix.
What's your definition of high-risk group?
There's a definition in the handbook. So the easiest way, because there's a huge list of them,
Okay, so
just think, in the handbook, but just think, is this person more likely to be at risk of pneumococcal disease? And it's easy to start from respiratory. Anyone with a respiratory condition is at high risk, cardiovascular, renal. So anybody with a chronic medical condition, particularly the kids you're about to vaccinate, if they've got a chronic medical condition, think, could it be high risk? Let me go and look. I think it's easier to go that way around. Otherwise, you've got about 4 pages of homework that you'll never remember. Yeah.
But go online, because it's changed. What? Go online, is it online handbook? Yeah.
Yeah, it's online.
Just recently changed.
It has. And also, it may change again, so watch it, because we're in discussions about who is the high-risk group that are funded. But even so, if somebody you thought was high risk, you'd still give it to them on the private market. You know, it's not like the funded is the only list of high risk, okay? Now, my problem is for the elderly. Pneumococcal vaccine is not funded in the elderly at all, except for a very small group of high risk, like people with no spleens. Is there a role? So this study looked at what we call the CAPITA study, looked at high-risk groups, the CAPITA study looked at people over 65 years of age. They essentially showed on a population basis that it probably doesn't work, okay? So there's not a lot of point, I personally think, in using conjugate in every over 65-year-old. But I actually think we make a mistake in thinking that every elderly person's the same. And I think we should be looking at high risk, okay? So this is looking at every elderly person. There's a lot of very well people over 65. So my personal advice is that where we think somebody is at higher risk of pneumococcal disease, we should still be offering them PCV13 followed by P23. Now for me, top of the list is COPDs. And then after that, you can get as fine-grained as you like, depending on how much money everybody's got, okay? But even if we vaccinated all our COPDs, I suspect it's probably worth it. I haven't got strong evidence for this, you know, elderly and vaccination, but I just think COPD at such high risk in pneumococcal disease. This is weak evidence.
Do we only give just one?
And then the PCV13 you could probably boost after 5 years, but nobody's sure. The trouble is it's not really used in adults, so we don't know what to do with this stuff at the moment. But PPV23 is so limited. But yet pneumococcal disease is such a big disease in COPD. You know? So look, this is a difficult area. Nobody knows the real answer. So that's my current advice. There isn't any clear international advice here on this one.
Thank you.
Now, I think we're nearly out of time. I just brought these as extras, just so you guys...
For 4 minutes?
Okay, 4 minutes. Mitigation of pain or distress on vaccination. We've already talked about it. This is really hard to read, this one, but essentially we looked internationally at the advice about how to reduce pain and distress on vaccination, and there's some very effective methods. And the babies give rotavirus first. Rotavirus vaccine first. Sucrose reduces the pain and the sense of pain, and then breastfeed all the way through if you can. If the mother doesn't want to breastfeed all the way through, breastfeed as soon as you can afterwards. Okay, and then there's a whole lot of things in older kids, so that's breastfeeding, about good holding, and many of you guys will know this, about how you hold them well and close during vaccination. And then for older people, it's sort of simple things like breathing techniques, distraction techniques for the toddlers and the older kids. So we've just got a list of these things here. There's a couple of other sheets on it. Okay, so we've got these sort of advice around. So I've got that, and the other thing. Oh, the other thing is, it is about communication. I love this, eh? You know, like we knew the science, but we didn't tell anybody. It just breaks my heart, eh? So I think I won't talk about it, but I think the point is that when you're thinking about vaccinations, it's actually about our ability to communicate. The number one issue of all is if the person trusts us as a healthcare professional, we will get higher uptake than anything else we do in medicine. It doesn't matter about health promotion and what the ministry says if they trust us as a healthcare provider. And these are the reasons people often refuse. So some people see their kid as low risk of disease, so I took the disease. You know, go, well, that's okay. You know, if you're not going to ever take your child out, if you're never going to a supermarket with your child, you never go to anywhere with family or friends, no problem. You don't have to vaccinate. You know, you can talk up the disease. I'm not quite as blunt as that, you know, but you can talk up the disease. But, you know, it's a real one. Well, look, if you think about hepatitis B, you can delay until your child is exposed to blood in the playground. You know, so one vaccine you could delay for, but pertussis, you can't delay, you know, unless you never take your child anywhere. So that sort of argument. This one's really common and we're missing it, people who are scared of the vaccine event. So I think putting a lot more effort into pain mitigation and making people feel supported will really reduce this. A lot of people just avoiding vaccines because it's nasty and hard, so the more we can support that, and I think we often miss that. They'll often say, you know, I don't believe in vaccines, and often they're just a bit scared. What we call the vulnerables, these are people who are just lost between providers, you know, often low income, often young solo parents. These are the ones that need outreach services, okay? They're pretty easy to identify, eh? These are the ones who chronic runny noses every time, vaccinate them. Sorry, my kid's got poor health, can't be vaccinated. Always got asthma, always got a runny nose. Let's be more confident about them, okay? And these dudes, once we've decided about all of these groups, they're fine. They're about 2% and they have not increased. They haven't increased. They're increased in some areas. If any of you come from the West Coast or Motueka, Waiheke Island, sorry folks, have I got someone here? Sorry. Kia kaha. So on the whole, they're about 2% of the population. There is a problem when they're in big groups. And then, oh, thank you, alternative lifestyles, yeah. So these people can be a problem, but overall, you know, if we can get to these groups well and understand their questions, we can vaccinate well, okay? I just reflect, we've got the Paediatric Vaccine Research Review because, you know, you guys have got nothing to do when you're sitting in bed at night, you're bored, it's such cool stuff to read. Yeah. That's it, I think they need a cup of tea.